Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, everyone. This is another episode of Parallax. We are in unprecedented times, and this is the midst of a pandemic, and we've done our best to get our listeners educated on COVID-19 pandemic and the severe acute respiratory syndrome coronavirus 2 infection. With that introduction, and I think the listeners will appreciate why I started with that introduction, I have with me on the show today Dr. Jagmeet Singh, Dr. Jag Singh. Dr. Singh is professor of medicine at Harvard Medical School. He's the former chair of clinical cardiology and a cardiac electrophysiologist at the Massachusetts General Hospital in Boston, Massachusetts. He has had a phenomenal career as a cardiac electrophysiologist and has published several seminal works. Is someone I personally look up to emulate a career in academic medicine. So without much further ado, Dr. Singh, welcome on the show and thank you for your time.
Thank you, Ankur. Delighted to be here and looking forward to the conversation.
So Dr. Singh, I always start the show by asking my guests about their journey as to their journey to where they are now. How did the journey begin, and what were the motivating factors and career paths and choices and decisions that you had to make for you to be able to get to where you are? So how did this all begin for you?
That is a very interesting question, has many parts to it. And hopefully I can finish that in the next 45 minutes. No, I'm just kidding. So, to give a little bit of background, I was born and raised in India. I was actually born in Delhi. My dad was in the army, and so I grew up as an army brat and changed almost 8 schools. I landed up in doing my medical school in Pune from a hospital, from a medical college called BJ Medical College. Subsequent to doing that, I trained in internal medicine there itself for the first 3 years, and then went to do some cardiology training at KM Hospital in Mumbai, where I got the P.N. Berry Scholarship to go to Oxford, where then I did my doctorate, my DPhil, in cardiovascular electrophysiology related projects. So it was more on repolarization dynamics, and it involved translational research work, both at the basic science level, but largely at the clinical level. So after finishing my doctorate, I actually got myself into a fellowship, a research fellowship at the Framingham Heart Study in cardiovascular epidemiology. And once I was in the midst of that, I got my foot in the door at Mass General to do my residency, subsequently my cardiology fellowship and my cardiac electrophysiology fellowship, all there itself. And then I came on as staff in 2003, and subsequent to that, I started my own program called the cardiac resynchronization therapy an advanced cardiac therapeutics program, something we call as the REACT program, and which I led for, I think, a period of 10 to 12 years. Subsequent to that, I came on as the clinical director of the cardiology division, I think in 2015, did that for almost 5 years. And here I am. So in the process of now, I would say, leading a clinically active life and clinical research, and really looking after patients.
Wow, quite the journey and quite the career. Those are very well respected institutions in India. I'm not sure a lot of the listenership would know about them, but I certainly know about them. From my roots in India, and I still have family in India and a lot of friends in Mumbai and Pune. BJ Medical School and then KEM are still pretty much at the top of the pops, as you would call them, when it comes to the cadre of students that they produce and groom. It's fascinating that you had that detour into Oxford, and then came over to the US. So incredibly rich journey, I would say. Translational science, epidemiology, and then electrophysiology. It's a great combination. So you've been in Boston now for several years. What about Boston enthralls you? Keeps enthralling you? It's my favorite city, by the way.
Thank you. No, so I've been in Boston now for, I think, almost 24 years. I came to the U.S. in 1996. And, it's a phenomenal city. I mean, this is honestly home. It's the only place I've lived in the U.S. since coming here. All my friends and colleagues and family all are in and around Boston. And the city itself is phenomenal. I mean, it's got so much of depth and breadth in the academic end of things that continues to enthrall me, especially from the medicine perspective. But even as a city, it's so culturally diverse, and the sports teams out here are fantastic, and we're all big fans of all the sports teams out here. So there's a lot that has kept me here, and then obviously Mass General Hospital is such a phenomenal place to work in. And whenever I've thought of saying, okay, maybe I should look around, it's tough to find a place that compares as well with Boston and as well with Mass General Hospital.
Yes, I don't blame you when you recite words like Boston and Massachusetts General Hospital. Definitely, clearly one of the best cities in the world, and clearly, arguably the best academic institution to work in. Tell me a little bit more about your academic life. How hard or how easy has it been for you to balance a career as a clinician and then a career as a clinician scientist? Because I know you fulfill both of those roles extremely well. And for someone like myself, who is in the early career phase, like we were talking off the line, I'll be finishing 3 years this summer. And most of our audience and our listenership is fellows in training or early career cardiologists, or perhaps even, I hope, perhaps mid-career. I mean, the people like myself look up to you and your career. Just tell us more about how you've balanced that act for yourself.
Sure, absolutely. So, I'm going to take a step back and probably elaborate why I made certain decisions along the way. And the reason for that is because I think for somebody to be able to, if I may call myself successful in research, I think it's really important that you have to be passionate about it. And to be passionate about it, I think it's really important that you have to be true to yourself regarding why you're doing it. what is driving you, and then most importantly, doing it in the arena that you feel, most engaged in. So I'm going to take a step back and tell you that when I first got into Oxford, my project was a basic science project. And within 3 months itself, I quickly realized that, I did not have the aptitude for basic science, primarily because I was not patient and I was just not overtly excited about doing patch clamping in single cardiac myocytes. So I converted my PhD into a translational one that actually involved clinical research. When I then moved to the Framingham Heart Study and did cardiovascular epidemiology, I think I learned a whole lot about clinical trials and epidemiology. That when I finished my EP fellowship, I actually wrote my first K23 grant, which is an NIH grant for doing some cardiovascular epidemiology work, looking at sudden death and looking at electrophysiological markers for sudden death and the like. I got my K23 results back and I was very high up there and was almost guaranteed that it was a successful application. But I sat back and, spent some time in introspection and felt that, it didn't wake me up in the morning. And I really wanted to do something that woke me up every morning that I was completely engaged with. So I actually turned down my K23 and decided that I wanted to do clinical research and clinical trials. I wanted to do something that was so intrinsically connected with my day-to-day clinical care that I could have an immediate impact. So I actually spent the next 2 years reinventing myself as a clinical trialist, where I started small clinical research projects at MGH, but at the same time started getting engaged in clinical trials at a national level. And I found that gave me immense joy. And since I was able to overlap my clinical interests with my clinical research and with my patients, there came a time that I couldn't truly distinguish sometimes, between research and clinical work because it was all intermingled in such a seamless way that I felt fulfilled on both ends. So, and I know this is a long-winded answer to your question about balancing academic life with the clinical end of things. And I think finding a strategy where you feel fulfilled and you're happy about doing both clinical work as well as research work and a way that they seamlessly integrate, I think allowed me to find that balance quite easily. Obviously, it requires a fair amount of work. It requires a fair amount of time educating yourself. But if you find an area that interests you and something you're passionate about, I think it can happen quite well.
Yes, no, I actually wanted to thank you for the long answer that you give because there are so many learning points in that answer. Most important take home for me was to just be true to yourself. A lot of us get into, for example, just to garner some lessons for myself as well as for the audience. When I got into research, it was a necessity because when I came into the US, the purpose of coming was to be able to get into a cardiology fellowship. That's why I came here. And I thought I would be able to do that, but I did not know that I would have to repeat my medicine residency. So when I was repeating my residency, I would often get that feedback that, forget about cardiology. It's extremely competitive. You have to be embellished with research if you have to even be considered competitive. The fact that you're a foreign graduate and on a visa. So for me, it was a necessity. But I actually, so early on when I got into research, it was more about getting published and making sure that I had a competitive resume for a fellowship application. And then I think some point during fellowship it changed, and I had that moment where I said, it's now that the fellowship is secure, I really should focus on taking up projects which interest me, and like you said, which wake you up excited in the morning, because you think you're going to derive new knowledge which would change or enhance patient care or outcome in some way, shape, or form.
Absolutely. One of the first things I tell fellowship candidates when they're coming to interview, or even actually resident candidates when they're trying to find out about fellowship, I tell them you may have come in here with a story. It's okay to change your story. You do not have to be wedded to a story that you developed in medical school or during a residency, because over time your interests change, and you may not be as passionate about something, or something may not be as glamorous or interesting as you thought it would be. And it's okay to change your story, but it's so important to be true to yourself, because that's the only way you're at peace with yourself. Otherwise, you're living a life for other people. Or, I always try to define or distinguish between satisfaction and success. And I think success is oftentimes how other people measure our lives, and satisfaction is oftentimes how we measure the work we're doing. And I think it's so important to kind of be sure you're not mistaking one for the other. And the only way to do that is being honest to yourself.
Yes, this is such great wisdom, right? And I love it the way you've put it. And I think it's an extremely important message, is to have the clarity in your mind to be able to distinguish success from satisfaction. Because I think what will truly give you joy and peace and happiness is satisfaction. I think success is to me, at least, that's how I've learned about it, and I've perceived it as, I've dealt with both failures and successes. Is I think to have a barometer within yourself where you are at a place called equanimity within yourself, and you are just a silent observer of whatever's happening to you or in your life. And you're constantly being a student of the circumstances that life's throwing at you. And the only I use the word student because the only goal then is to be able to come out as a better person, as a better physician, as a better individual, as a better family man, or as a better friend. So I thank you for taking the time to actually define those words for our audience, success and satisfaction. And, I couldn't agree more that change is the only constant. And, I think one keeps changing as a person, one's priorities keep changing as, one goes through life. And, there's a lot of learning from what you said. So, thank you for your honesty and your candor and sharing your insights with us. With that, I think we should talk about the late-breaking trial that you presented. Talking about research this past year in November, which was published in JAMA. It was on a population of patients which is evolving, and we keep learning more and more about them. There is actually a designated subspecialty within cardiology now, the cardio-oncology subspecialty. So, I'm sure people want to hear more from you than from me on this topic. So I'll let you, take the center stage here.
Sure. No, absolutely. So one of the things I didn't, elaborate on before is that, after I started the multidisciplinary program that I did in patients with heart failure and implanted devices, which is called the REACT program. So it was the Resynchronization and Advanced Cardiac Therapeutics program. This was a multidisciplinary program, which was the first of its kind in 2005, 2006, that actually brought together heart failure electrophysiologists, imaging specialists, and oftentimes even cardiac surgeons. And it was a one-stop shop and continues to be a one-stop shop where patients are seen with all the three subspecialties together at the same time, really providing an integrated opinion about care strategies. So when that came to be, it got a lot of national attention, obviously, because it was the first integrated program, and it proliferated into several clinical trials. And I can tell you at one point in time, I was probably running almost, my group was running, let's put it this way, about 20 to 24 clinical trials at any given time over the period of the last 10 to 15 years. And all these clinical trials were either in enhancing selection strategies or enhancing implantation and device implantation strategies for patients with heart failure, or in follow-up strategies to see what you can do better through integrated care and other strategies to enhance outcomes of these patients. So, one of the things we noticed while we were, taking care of these patients with heart failure, that there was this population of patients who had chemotherapy-induced cardiomyopathy. So patients who had actually survived cancer and now had heart failure, and were kind of looked upon as patients that, really had gone through a double whammy and were unlikely to benefit from any other interventional strategy. So this was back in 2010 or so. One of my residents, Olu Ajijola, who put together a series of 4 or 5 patients. This was retrospective, 4 or 5 patients with chemotherapy-induced cardiomyopathy who had wide QRSs, so they had an intraventricular conduction defect. So that means their hearts had mechanical desynchrony. And we offered cardiac resynchronization therapy to these 4 women. And it turned out that they did actually pretty well. Their reverse remodel, that means their ejection fraction significantly improved. They had reduced hospitalizations, and their clinical course actually seemed to move in the right direction. With that success, we felt that maybe there is a larger subset of these patients out there in the real world being followed potentially by cancer surveillance programs that may not be getting the benefit of resynchronization therapy and just have protracted heart failure and eventually die from heart failure. So with that as the backdrop, I, along with Dr. Arthur Moss, as you know, has passed away, was legendary in device trials. This was the first trial that he allowed somebody else to become, he was my mentor, to become the principal national investigator. It's a study called the MADIT-CHIC study. So MADIT studies, everybody knows the CHIC study is chemotherapy-induced cardiomyopathy. So this was a multi-center study set up with 12 cardio-oncology programs across the country, looking for these patients with cardiomyopathy and conduction defects, and then trying to see if resynchronization therapy can help them. So over the course of, I think, 2.5, 3 years, we recruited about 32 patients with these phenotypes and gave them cardiac resynchronization therapy. And the short answer was that these patients did really well. Almost all of these patients had significant reverse remodeling of their hearts. None of them had heart failure hospitalizations over a 6-month period. So obviously it was a short follow-up period. And this was recently published in JAMA in November of 2019 and was presented as a late breaker at the Heart Rhythm Society in May of 2019. So again, I think it is the first device therapy trial in this subset of patients, of cardio-oncology patients. So I think it got some notoriety because of that. But I'm delighted to say that, patients who survive cancer and develop heart failure at least have some therapeutic strategies that can still make them feel better again.
Yeah, no, just incredible work. Congratulations for conducting the study and presenting the data and publishing them in JAMA. Do you foresee, I should ask if there is an ongoing longitudinal follow-up? I would assume there would be for these patients. And are you enrolling, are you enrolling more patients, or you think this has now become a part of your practice, or at least part of the cardio-oncology program at the MGH?
So in all fairness, I am not a cardio-oncologist. But having said that, I think the cardio-oncology community, which is, exponentially growing, not just in numbers, but also in influence, I think are seriously looking into this. They're also developing a lot of registries for device therapy in this subset of patients. And device therapy doesn't necessarily have to be cardiac resynchronization therapy, but could even include pacemakers and ICDs and the like. So yes, I think it makes a lot of sense to have more longitudinal, long-term follow-up in these patients. And I'm sure there are studies that are underway, but we as a center have not pushed it forward at this point in time because of other competing interests.
All right. So, with that, I think we should talk about another aspect of this episode, which I think is going to be very important as well. As has been, your career and your journey. But, I think one more important aspect of you is that you are now a pandemic survivor. You've survived COVID-19, and you've had quite the battle. Thanks to your wife for sharing your inspirational journey with all of us on Twitter. And for the listeners who have not read the feed, I would highly encourage to read that Twitter feed, because you would learn a lot about the disease process and the struggles for patients, caregivers, and hospitals, healthcare systems, and just all of us, because we're all in this together, obviously. So tell us. First of all, I'm grateful that you're here and you've agreed to share an incredibly personal journey and experience with our audience and with our listeners. So I deeply appreciate that, and I sincerely thank you for that. And I'm so glad that you are on your way to recovery. But just walk us through what led you to getting tested and what ensued from there on end.
Sure. No, absolutely. Sometimes I think my claim to fame is probably this COVID-19 infection more than anything else that I've done. And I jokingly tell my wife that I'm now called the COVID cardiologist. So to give you a bit of the backdrop, so I was probably amongst the first few patients to be infected with COVID at Mass General Hospital for certain. Certainly not the first, but amongst the first few, I would say. So I don't know how I got the infection. I was traveling the week prior. It was domestic travel. I was speaking at the Heart Rhythm Society Industry Symposium. And then subsequently, I spent a day in the lab doing an AF ablation and implanting a couple of devices, and spent the next day in clinic seeing patients. And when I went home, I felt a little poorly. And then the next morning, that's now March 11th. So this all goes back almost 33, 34 days. March 11th is when I actually woke up with a severe fever and a high fever and body ache and myalgias. At that point in time, almost instantly, I kind of knew this was different. I knew that it was not the flu. I was not congested, did not have any sinus congestion or upper respiratory tract infection or anything like that. And although the COVID, fear was around, there were still no, institutional laws or strategies. Sorry, not laws. There were no directives that we were not to travel, and people were not that worked up about it. But having said that, so when I woke up, I felt ill. I called the administration of the hospital and then asked them to allow me to get tested because of my contact with patients. And then I was tested in 48 hours, which turned out to be a positive test. So I was quarantined, and my wife was also right from the day one. My wife is an oncologist at Mass General, and she also was self-quarantined right from day one of my developing the fever, because there was this, COVID conversation, at least, that was going on at that point in time. So I stayed at home, thought I was getting better. The fevers were kind of getting better, but somewhere around, I think, March 19th or so, I started getting a headache and developing a cough, and was a little short of breath. So despite the fact that I felt things were under control, it suddenly took a turn for the worse.
So this is a week into when you had the fever, right?
Correct. So almost 8 days now, I think. And it was at that point in time that Nupur, my wife, said that it's time to go to the hospital. So she, could not take me down the stairs. So we live in a townhouse. I would have to go down 3 flights of stairs, and it was not possible. She landed up calling 911, and they took me to MGH, which is actually just across the road from where we live. And I was rushed to the ER. In the ER, they did a chest X-ray, which I had, I would say, an opportunity to look at. And it was a complete whiteout. So both the lungs were significantly infiltrated with the bilateral pneumonia. I was breathing all right. I was not too short of breath. My oxygen saturations were somewhere in the 94, 95 range. But they were concerned enough, and it was early enough in the pandemic that folks didn't really know exactly, what the clinical course would be. So my caregivers in the ER then landed up getting a CAT scan, which showed that the pneumonias were probably even worse. And they felt that there was very little residual lung tissue that was working normally, and that it may not be a bad idea for me to go to the intensive care because there was a high likelihood that I might need a ventilator. And probably at that point in time, there was a lower threshold for folks to get a ventilator too. So landed up in the ICU, where I stayed overnight. Fortunately, my oxygen saturations hovered in a normal range, that they felt that maybe I can be managed conservatively. And so I was shifted to the regular COVID floor. Obviously, in the ICU, I was consented for my code status, for intubation, for invasive hemodynamic lines, should I need them. So I was kind of prepared, obviously, for the worst, but it was nice to know that my SATs didn't drop, and then I could be shifted to the regular floor. I must say that when I was in the ER, I was asked almost on a, half-hourly basis whether I was tired and whether I wanted to get intubated. And that was a little disconcerting, certainly, for me at that point in time. But landed up on the COVID floor. And then I stayed there for another 8 days because my fever did not get better until the last day before I got discharged from the hospital. So a total course of almost 21 to 22 days with fever. I lost a significant amount of weight, so almost about 14 to 16 pounds at the end of it, and probably, just from the fever ravaging the body. But one of the other disconcerting things, obviously, along the way was my inflammatory markers, that is, the CRP, the ESR, and I think they were also measuring LDH and significant lymphopenia, kept getting worse during my early days on the COVID floor. And each of these markers, obviously are suggestive of poor prognosis. So putting it all together, it was, I was amongst the fortunate few not to get ventilated and get better. But nevertheless, there were parts of this journey that I think were educational, certainly, but along the way also quite disconcerting.
How was it to deal with the diagnosis with the degree of illness, its severity on an emotional level, both for you and for your family?
Sure. I think I may have been emotionally labile at times, um, uh, but I think it is an extremely isolating illness because your family is not allowed to be in touch with you. You are, cordoned off. Uh, but your lifeline, at least my lifeline, was the nursing staff at Mass General. And your FaceTime is a beautiful thing. So you can still be in connection with your family, but you're not allowed to, see them personally at any point in time. So, I think it can be very isolating. I certainly, I think it was worse for my family. I was fairly obtunded during several parts of this clinical course, but they were in real time kind of experiencing this, and were obviously worried that I was going to go down a path that nobody wanted me to go down.
Were you given any of the medications that are, even at this point considered investigational? For example, hydroxychloroquine, azithromycin. What about managing fever? Like, were you given any antipyretics? I know there is a relative contraindication for use of ibuprofen.
Yeah, no, that's spot on. So, I think one of the things my wife was trying to avoid giving me was ibuprofen at home. And that, is actually the only thing that brings my temperature down. So it was a bit of a battle between the fever and not taking enough antipyretics that I think really kind of made me feel unwell too. And nobody really had the right answers. And we were working off this, literature that was constantly changing, coming in. So that was a bit of a challenge. And I believe people are more relaxed now about giving ibuprofen. But at that point in time, it was certainly something that, we were underdosing me with. And as a result of which my fevers kind of consisted and persisted for a while. But nevertheless, I think when I got to the hospital, even there was some element of reticence to use ibuprofen, and only when I had a really high temperature was I given naproxen or something to that effect. Yes, I did get hydroxychloroquine and azithromycin, which was, and I think may still be, I'm not sure, a part of the MGH protocol. And I think the MGH protocol at that point in time was working off again the early literature that's suggested that it could have benefit. I think we've learned now along the way that there are several studies that have indicated otherwise, that it may not benefit patients at all. And in fact, there are some studies even suggesting that there could be some cardiovascular side effects from it. But I got it. I tolerated it well. And I also, at the same time, was enrolled in the remdesivir trial, which is the same drug or antiviral drug that was used for Ebola. It's a double-blind, randomized controlled trial, so I have no idea which arm I was in. But that was, again, something that I got additionally along the way. It's tough to say if any of these helped, or whether the disease just took its natural course. But I'm hoping that the results of some of these studies will give us some direction.
Thanks again for sharing your experience. It's frightening, it's terrifying, it's also enlightening. But it just sort of recapitulates the self-realization that, it just we're so vulnerable, and we're also just nobodies. We could just totally be succumbed to any illness, and at that point in time, it just brings you so much closer to truth and life and reality, and to your point of pursuing your passion. I mean, I think you should pursue your passions relentlessly. Be humble and kind to everyone, because you're and hope that in that journey you're going to impact others in ways that they may be thankful for. But just living a truthful life, and a life full of purpose and passion is something which I think, to me, learning from your experiencing that's the most drive home point for me.
I think you're spot on, Ankur. Life is very fragile. 1 minute you're here and 1 minute you're not. And I think it's so important that we have to be real. We have to know, what we're living for. And I think one of the most important things is, our family, and then our friends. And I think really giving importance to our day-to-day relationships, and considering every opportunity to communicate as a privilege, because who knows that you may not have that privilege, in the next minute. So I think it certainly put life in perspective for me, and I think it helps me evaluate, what the next things I would like to, spend my time doing. But I certainly, I think looking after patients, repaying my debt by getting better and getting back on the front lines for the COVID fight is something I really am looking forward to. As I've said before, I almost feel like a draft dodger. I fell ill at a time when I was needed, but hopefully, I'll be able to get back and help out again.
Well, we wish you all the best, and we wish you a complete recovery. And thank you for your time and your generosity and your courage and your transparency to share your journey with us. And I look forward to staying in touch and constantly learning from you and your work and your service to patients. Thanks again.
Great. Thank you, Ankur, and thank you for having me on. Take care.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.